Hello, everyone. I am Matias Sosa, bariatric and metabolic surgeon. Thank you, Guillermo and Bruno, for your kind invitation. It's a great pleasure to be here with you, sharing our experience in health and technology. I am here to talk about intelligence in health systems. So let's get started with the presentation. As I mentioned before, I am Matias Sosa from Argentina. I am a bariatric and metabolic surgeon. This is an obesity surgeon. I am here to talk to you and share my experience in intelligence in health system, from artificial intelligence to cost effectiveness. First of all, I would like to thank Guillermo and Bruno for your kind invitation to the invitation to be here in this great event. For me, it's an honor to share our experience with all of you. When we define intelligence, we can find a lot of definitions and meanings, but the one what I like most is the ability to solve problems and to overcome adversity. But when we talk about artificial intelligence, according to the according to the World Health Organization, in its last report, it is defined as the ability of algorithms to learn from data so they can perform automated tasks without a process having been programmed explicitly by a human. So what does it mean? Is to leave aside the human in its process to learn and to perform tasks and solve problems. When we must apply artificial intelligence in medicine, there's an old and ancient precept that is called primum non nocere in every medicine act, which means in English, first do no harm. And that's because artificial intelligence has challenges and risks. For example, unethical use of health data, algorithm bias in patient treatment, cybersecurity crimes, and obviously environmental concern. There are some basic principles and top priorities we must focus in. For example, the human autonomy of privacy and confidential information, patient consent and regulation, well-being and security, taking quality control and improvement to a constant update, transparency, easy access, promote democratic debates, and also responsibility, accountability, sustainability, inclusion, and obviously equity, because the main reason of artificial intelligence we must follow is to reach people and close the gap between health systems and communities. Benefits are limitless, obviously. With artificial intelligence, we can diagnose, we can improve diagnostic haste and accuracy. We can ease clinical access care. We can support health and pharmacological research. But the most important thing here, I think, is to support healthcare by helping surveillance diseases, helping with control of epidemics, managing health systems, and obviously closing the gap to healthcare access. And how do we close the gap of health access? Artificial intelligence in medicine are this and beyond. In these cases, we can see how artificial intelligence can help us treating odontological patients with the design of perfect tooth implants, or on the upper right image, helping a surgeon to reach some hidden or very hidden organs without, or at least reducing considerably the risk of injury of another organ. Or in the image below, when we can that it's called image guided surgery, where when the patient is injected with a contrast called ICG, and in this way we can see more clearly with the change of a button of the camera which structure needs to be taken out or not during a surgery. But closing the gap also means removing barriers. And here, artificial intelligence have a great impact in healthcare and in access to telemedicine in particularly. And when I talk about telemedicine, it's not only just like this picture when there is a doctor and a patient in the comfort of his or her living room, but also telemedicine means a lot more. Means a doctor sharing his knowledge with another two colleagues in a rural area, very far away, along so many kilometers or miles away, talking about patient cases, treatments possible, because knowledge is power, and knowledge would be the power to improve and enhance communities that are very far away from big cities. How do we do it? In this case, and in my particular opinion and experience, I run, as I mentioned before, on an obesity center called CITOS, and we had a huge milestone that defined the way we could bring access to obesity surgery, for example, and in my case. And it was the COVID pandemic. There was a before and an after of the COVID pandemic, because we have to reinvent ourselves to reach patients and for patients to access health care, in particular bariatric surgery. In our case, patients reach us through the web or social media, and we can bring experiences like this one. Here is the case of Marian. He was a very few days before the surgery, and here is the post-operative photo after 7 days after her gastric bypass. What I mean is that in this case of Marian, I met her in person a few minutes before the surgery, but I had so many Zoom meetings before that helped her and us to define a bond between patient and doctor that let us arrive and achieve great results. This is the other case of Gisela. She's about 200 miles away from here, from my city. And in the left picture, we can see a Zoom meeting carried out a few weeks before her surgery. And in the right picture, we can see how we celebrate the month after her surgery with an Instagram live. The same thing happened with another patient who reached you and sent you a message saying that, I don't know, she can wear jeans again due to the surgery, or now she had to renew her closet, or in particular defining and celebrating every moment with her family. So being intelligent not only means artificial intelligence, but in bariatric surgery in particularly, being intelligent means saving time, resources, and money. The other pandemic beside COVID was the obesity pandemic. And in the US and Latin America, 6 out of 10 people suffer obesity. Comorbidities that are the related disease, such as diabetes, hypertension, cholesterol, and so on, are very frequent in this population. For example, insulin costs vary from $70 to $90 per week in the US. Obese people life expectancy is 10 to 15 years less than non-obese people. And this is why science and particularly scientific journals can show us what is the best way to approach a patient with obesity in particular. We can see how surgery benefits along the post-operative months, not only with one particularly surgical technique, but also comparing it with no surgical group. But this can be translated also to other diseases such as diabetes, which significantly are improved by surgery, not at 5, but also at 10 years. And we are having these patients so far away, very close to the obesity center, which is treating them. According to cost effectiveness in bariatric surgery, we can see that there is a huge saving in patients which are obese and undergo bariatric surgery in the numbers of the health ministers, particularly in the UK. And this is another scientific paper that shows us how bariatric surgery can improve and can save money for the health services, national services, in another paper of the UK. So beyond the economical benefits, there is a benefit that it is not measurable. That is the life expectancy improvement in every patient with obesity. And in this case, artificial intelligence can show us the lead or the path, to achieve that goal, that is to enhance and reach people which is outside our communities and is left behind of the healthcare system currently. I think that for our future, our mission is to be intelligent, artificially or not, but we need to be intelligent. Thank you very much for your invitation, and I would like to see if you enjoy and profit my experience with artificial intelligence applied in my hometown.